Okay, we're going to go ahead and get started. Good afternoon, everybody, and welcome to today's Grand Round session. My name is Tziporah Rosenberg, and I'm the Associate Chair for Education. It gives me tremendous joy and pride, actually, to introduce our panel of today's speakers, which includes myself, but I'm not going to start with that. We have to my right Dr. Jennifer West, Director of Psychology Training, Dr. Aspen Ainsworth, Director of the Consultation Liaison Fellowship, Dr. Laura Cardella, Director of Medical Student Education and the Clerkship Director, and me. I'm sort of the bonus person. So today's rounds is going to be a little bit different than usual in that we're going to do a broad overview of education here in the Department of Psychiatry. So I'll get us started with that portion. And then we're actually going to take turns featuring innovative approaches to education and training. I think you're really going to be amazed at what my colleagues share, but I can also say my amazement stems from knowing that this is really just a drop in the bucket of what they and others of us in education and educational leadership do every day. So welcome to all of you here in class of 62 and those on Zoom. We have no disclosures, but for those of you who are wondering what the title of our talk means, I'm not going to tell you right away, but I will ask you, as you're listening to us get started, to think for just a moment about an educational experience you have had that stood out as very positive, and then think about one that stands out as something opposite. Just hold on to those for just a second. And what I'm going to set up for you is a little bit of a snapshot about why education is so vital in terms of our mission here in the Department of Psychiatry. We have no disclosures, but we will start by talking about mission. My hope is that most of you know that education is one of several vital missions here in our department. But if we look broader, even at something like the Institute of Medicine, we know that the Academic Health Center really serves a number of purposes, including being a constellation of functions and organizations committed to improving the health of patients and populations through the integration of roles across missions, particularly including not just clinical, but also research and education. Here in our department, not only are we focused on training highly competent, highly skilled clinicians of today and the future, but we also strive to build, enhance, and diversify our own community. This is hot off the presses data. I understand from Mary Lee that a recent look at our current faculty is that 67% of our current faculty trained in at least one of our training programs. I didn't ask her who trained in multiples, but probably more than one, which is a very impressive look at how education is also a pipeline for future faculty and for broadening our community. At the same time, Dr. Lee mentioned in the first grand rounds of the series that our department's core missions are vulnerable to siloing. So integration really is the spirit that ensures the vitality of each one of them, and education is really no different. So for those of you who are wondering what education looks like in our department, I'm going to give an extraordinarily brief overview of most of the educational efforts that I at least could remember, and I'm certain there are others. The first is undergraduate medical education, where we are a required clerkship for the medical students here in our institution, having over 100 students per year pass through our department. You can see here the curricula that stretches across each year, each phase of their learning, such that by the end, they have everything they need to know about psychiatry. Dr. Cardella is going to talk a little bit about that. In graduate medical education, we have two main arms. One is our general residency, which welcomes 8 residents per year for a 4-year training experience across a number of different kinds of settings that are listed here, and with a lifespan orientation, as well as specific didactics and clinical experience and supervision to help them cultivate specific skills in things like interventional psychiatry, treatment of substance use disorders, serious mental illness, and forensics. We also have a number of fellowships, including geriatric psychiatry, consultation liaison, forensic psychiatry, child and adolescent, and our brand new addiction psychiatry fellowship that Dr. Mathis and her team described last week. Each of those fellowships welcomes 1 to 4 fellows per year and is 1 to 2 years in duration. In psychology training, we're also accredited by the American Psychological Association and APIC. We have a doctoral internship lasting 1 year with both adult and child tracks. 4 positions in each of those tracks are offered annually, with an opportunity for interns to specialize and very focused on robust rotational experiences that take them all over our department, but also other departments. We also have a postdoctoral fellowship that is 1 year in duration, both in child and adolescent psychology, as well as integrated care family psychology, with a number of those fellows in the latter group in our collaborative care and wellness clinics across specialty locations. There's more. We have family therapy training, which is a Commission on Accreditation for Marriage and Family Therapy Education accredited training program, which actually offers a degree. This is a very unique feature of a program like ours in that it's housed here in academic medicine, but graduates of this program leave a 2-year experience plus, if they're a part-time student, with a master's degree that actually enables them to satisfy the educational requirement for licensure here in New York State and elsewhere. But we also welcome a diverse student population with diverse career goals, some of whom are very interested in joining our community here as private practitioners, some of whom we have been lucky enough to recruit to become our clinical leaders and trainers, many of whom are coming back to this training program as a second career or a third career, all of whom are really mission focused in the ways that I will describe in just a moment. The Marriage and Family Training Program also has a post-degree training option in which these students and enrollees already have advanced degrees like master's degrees, medical degrees, and PhDs, but they're wishing for family therapy and systems-oriented training with a customizable program of study. What else does education look like? There are nearly limitless iterations of what it looks like to be in a thought exchange here in our department. However, I'm highlighting a few as well. In social work, we welcome interns from partner programs at Brockport and Nazareth and Roberts. We host nursing interns and students from across the region, including giving specialized training in psychiatric nursing. We welcome trainees for practicum from mental health counseling programs, both here at the university and elsewhere. We heard lots last week about strong recovery and the CASAC training program, as well as the new certificate program being offered. Turns out we're in education right now. Our Wednesday Grand Round series and the Romano rounds and the Angle rounds and our dice rounds are all opportunities for education and thought exchange. We have journal clubs, we have conferences, we have a shared didactic day, which is a brand new feature for this academic year, in which most of our training programs are coming together in the same day and time for doing their didactics, as well as creating opportunities for interprofessional learning and starting to understand how other people in our healthcare teams are taking in, making sense of, and using the same information. How else is education happening? I'm not going to point at people because my mother told me it's rude, but education is happening through everybody here in this room and on Zoom. You are an educator, whether you know it or not, partly because every day in every unit, we have learners and teachers who are all working in relationship with the fine clinical work that is happening in the hopes of the best service to the patients and families that we are working with. So for those of you who are intrigued about the title, and even for those of you who weren't, I'm going to share the whole quote here by Sidney Harris, which is that the whole purpose of education is to turn mirrors into windows. There are several different interpretations of this, but the most common and the one that resonates most for me is about shifting from looking inward and being self-reflective to looking outward, to demonstrating a sense of curiosity and connection to the world outside of ourselves. When I think about what is the best of education that we all bring as educational leaders and as teachers, it is this act of inviting all of us to look outwards and through windows that we increasingly need to identify, open, and let the air exchange in both directions. I have taken a crack at a mission statement here for our educational mission that I will admit was only vetted by today's panel, but I think it is going to be something for our education committee to review. But the point is that we want to ensure that we are developing trainees and clinicians for the future that are biopsychosocially and systemically oriented, who are dedicated and compassionate, who use evidence-based principles and interventions, who are equity-oriented and who are ethical in their approach to providing safe care, but most importantly, that they are guided by the needs, the strengths, the health and well-being of the communities in which we serve, but who also embrace values. This is a lot of words. So many, this is like one sentence. It's like so many words. Embrace the principles of interprofessionalism, collaboration, lifelong learning, and mutuality. Without further ado, I'm going to hand off to our first innovation, which is going to be Dr. Ainsworth, and we're going to just take turns, and then I will round us out here at the end. Do you need me to do this for you?
Okay. It's nice to see a bunch of friendly faces. I recognize a lot of you and out there, but some of you are new faces to me. I'm Dr. Ainsworth, and I'm a CL psychiatrist and the director of the CL Fellowship. Have I moved it forward? No. Okay. Oh, I was using, okay. So I'm gonna first talk to you a little bit about the Consultation Liaison Psychiatry Fellowship program here. For those of you not familiar with CL Psychiatry specialty, it deals with the understanding and advancement of medical science, education, and health care for persons with comorbid psychiatric and general medical conditions, psychiatric care of patients who are in the throes of acute medical issues and in medical settings. So we've got clinicians embedded in the medical hospital, surgery, pediatrics, neurology, dermatology, oncology, transplant, lots of different places. Just giving you a couple more pieces of information about our CL Fellowship program. It is a one-year ACGME accredited program, and it was established in 2017. We take one fellow per year, and we've graduated 5 fellows from the program, 3 of which are current faculty here at the University of Rochester, including Dr. Pulley, Dr. Hitchens, and myself. The program, trainees complete the program after doing 4 years of general psychiatry residency, and it allows a fellow to sit for the subspecialty CL exams and become board certified in CL psychiatry. Okay, the slide's a little wonky, but so what's in a name? Consultation liaison. The first half is pretty obvious. CL psychiatrists do psychiatric consultative evaluations in medical settings usually, but the second half of the word is really a very important part of the name and what's in the job. So what is a liaison? A liaison is communication or cooperation that facilitates a close working relationship between people or organizations. It's someone who helps groups come together and work effectively. And that's what we're talking about today, right? We're talking about interdisciplinary professionalism, collaboration, education, learning, working together. So 50% of our job, 50% of our name, 50% of our job is about the liaison work. I would actually argue it's probably a little bit more than the other half. Because the liaison component is such an important part of this work, the ABPN has competencies that CL psychiatrists must achieve. So this is the language. To develop and implement comprehensive medical psychiatric treatment plans that address biopsychosocial domains, including utilization and input and recommendations from members of the mental health care team. So listening to our colleagues, hospitalists, primary physicians, other consultants, and representatives from allied disciplines. So what I see here when I read this is a lot of listening and collaboration. Diving in a step further, I've outlined a couple of the competencies that CL psychiatrists really work to learn and hone. So I've listed them here. Communicate effectively with a consultee. We're usually invited into care in typical consultation experiences. Skillfully manage transference and countertransference issues between patients, caregivers, and medical settings. I'm sure most people in the room are familiar with that practice. Demonstrate verbal and written communication that effectively conveys impressions with the whole healthcare team, not just the consultee. Be an educator. Educate patients, families, and our teams. And then help guide the team in executing effective biopsychosocial treatment plans. So all these, I'm pretty sure, probably strike close to home for many of us in this room, but these are explicit goals of the CL Psychiatry Fellowship Program. So how do we do it? We have many different rotations that help our trainees accomplish and gain and develop, hone these skills. But one that I'm highlighting today is our medicine and psychiatry service rotation. So we plop the trainees right in an immersive experience of multidisciplinary collaboration in this team that includes a lot of different folks with different training backgrounds, all working together towards a shared mission. So a little bit about the inpatient and medicine and psychiatry service here. As you can see, I've got a lot of our team players. There's medically trained physicians, a lot of trainees, medical students, psychiatry residents, nursing students. There's a pharmacology student, there's a psychology intern. So a lot of trainees, as well as dedicated nurses, social work, care coordination, pharmacology, psych techs, et cetera. So we really have a lot of members of the team in order to accomplish these robust goals on a med psych unit, because we try to tackle multiple issues at the same time. What is particularly important about this setting and helping teach some of those skills that I talked about is the consistency of the team. So you can imagine an environment where it's not the exact same set of people every day, but we're working within the same pool of people every day with shared missions. And so you can imagine for a trainee looking to, observe interdisciplinary communication, practice a skill, try it out, see how it lands, see if it was effective or not, receive feedback and come back and try it again, having a stable environment to do so, and team members that communicate with each other that can really facilitate the trainee's self-reflective process, and then facilitate feedback, and then facilitate, trying something new or tweaking it or doing the same thing, something different, which is a little bit different than the standard consultative experience in the general hospital, where a trainee might be working with, many different teams. And so really learning, the person that they're working with, they might see, one consultation with that other colleague, I don't know, once a month, so they don't have an opportunity to come back the next day and work through with that same team. So I've compared the CL psychiatrist and CL psychiatry fellows roles in the medicine and psychiatry service, and kind of shown you the vast interplay and how all the roles are really shaped to accomplish some of the communication goals and learning objectives. So one thing we do on the inpatient medicine and psychiatry service is that we proactively chart review all newly admitted patients from, throughout the week. When we're doing that, the trainee is learning how to listen to what this team has written in the medical record. They're practicing making sense and putting together those pieces. They're putting information into the chart, so they're practicing communicating their impressions in written form. The CL fellow and psychiatrist proactively review all the cases with the medical team. That's an opportunity to listen, right? Listen to the expertise of the medical team. It's an opportunity to practice asking questions and eliciting information from the team, bringing issues to light that the CL psychiatrist might be observing that the team is not aware of. Practice proposing interventions or proposing changes in the treatment plan. The multidisciplinary team meeting that happens every day is a vital spot. That's where we get the whole team together. And that's a nursing-led team meeting, which really capitalizes on the nursing team's expertise in the patient. It's an opportunity for the CL psychiatrist to listen, to also observe the team dynamic. How do we hear the team talking about this patient? See how the team is interacting with each other, and help the team kind of problem solve through issues together. Co-rounding evaluations are when the CL psychiatrist goes with the medical team, sometimes also nursing, social work, psychology, and sees the patient together. And again, that's a great opportunity where the trainee can learn to observe the interactions, right? Observe transference interactions. We can learn so much just by listening to the team talk with the patient. It's an opportunity to model certain ways of interacting with the patient to help the medical team out in working with the patient effectively. And then a couple of other places that really help us accomplish a lot of these goals. And then I will just give a shout out to the communication coaching program, which is an amazing program. And so the MIPS rotation is one of the sites that we have our fellow participate in that program. And that really just helps kind of drive home all these things that I've been talking about. It's also a place where we do 360 evaluations. So with that, I will move on to the next piece that I'm talking about, which is a project that we're working on, Dr. Cardella and I and some trainees for medical student education. So you'll hear more about medical student education from Dr. Cardella, but we've started a project to essentially evaluate the evaluators. We know that written evaluations of students are so important in conveying kind of feedback, strengths, areas for growth, and especially now with changes in other things like board scores to pass, fail, et cetera, really getting down to the nitty gritty and the granular detail of these evaluations is helpful. It's helpful for the students, and it's also helpful for the grading committee when we're going to assign grades to students, that we feel confident that we're assigning the grade that the student achieved. So this is just a little bit of a kind of a joke in the beginning. So are your evaluations good, very good, excellent, or outstanding? And when we actually look at when you're using those words, good, very good, excellent, and outstanding, if we kind of were to plot those on a bell curve, good, does that actually mean bad? Very good, does that mean slightly below average? Excellent, about average, and outstanding, quite good? So it can be really complicated as we kind of weed through language and issues like grade inflation. So the goal of this project that we've started is to improve the quality and usefulness of the written evaluations of the clerkship students. We're going to be starting small, but then hopefully expanding from there. Narrative evaluations have equal or better grading reliability actually than Likert scales. So we changed to that form a couple years ago, and we're really looking to kind of harness even better narrative evaluations now. You can imagine that with narrative evaluations, there's kind of increased heterogeneity, though, that invite issues like bias. And so we really need to be mindful about those types of things. So how are we doing it? There's a narrative evaluation quality instrument that was developed by our neurology service for the neurology clerkships, and it's also been vetted in medicine clerkships. And so we're using that tool. We're assessing a whole bunch of evaluations of the medical students by our faculty. And then our goal is to give individual feedback to evaluators, develop a pocket card resource, which some of you have probably already gotten that already, and then also work on some faculty development sessions, and then see if we've gotten better. This is a busy slide, but I have on it, on the very left-hand side is the actual tool. It evaluates 3 components of evaluations. One, kind of the number of performance domains commented on. That's things like clinical skills, clinical reasoning, fund of knowledge, written skills, oral skills, professionalism, initiative, preparation, and participation. The specificity of comments. So moving from qualifiers, which are essentially like adjectives and adverbs, very good, poor, excellent, outstanding, to evidence, which are because statements. So the overall performance was good because, XYZ, to examples, which demonstrate where the student demonstrated a skill specifically. So the specificity of comments, and then the last domain is the usefulness to the trainee. A lot of times, and I fall into this too myself, it's much easier to give positive feedback and to comment on strengths. But really, to do justice to our trainees, we need to help them grow. And the place that they likely have to grow more are the areas where they have challenges. And so it's our duty to talk to them and facilitate their improvement, to give formative feedback and summative feedback and help them work through how to improve those things. That's our job. So the usefulness to the student. So both the kind of positive and the constructive feedback to help them grow. So you'll be seeing more and hearing more from us as we take this project forward. We're really excited to work with everyone on it and learn ourselves. With that, I will turn it over to Dr. Cardella.
All right, thank you all. I'm excited about this narrative evaluation project myself. I think students deserve to know what they're doing well and know how to get better, and I think that's our job. But it is difficult, to write a good quality evaluation. So I'm looking forward to learning more myself as well. So I'm Laura Cardella. I'm a child adolescent psychiatrist and the director of medical student education. And I'll talk specifically today about the psychiatry clerkship, but I also teach in the first and second years and help oversee electives as well as residency advising for application season, which is right now. So wanted to give a very brief overview of the psychiatry clerkship. You all, many of you know or are living it right now. We have medical students here in the audience and residents and also faculty members. We have 104 students come through our clerkship every year. Those students come to us in 4-week blocks, 8 times a year, and we try to give them clinical exposure in things that would be helpful regardless of what field they go into. So a wide variety of clinical experiences, both at their primary clerkship site, which as you can see is many inpatient units, also the consultation liaison teams, CPEP and partial program, and also we're very grateful for our partnership with Rochester Psychiatric Center as well. They all spend at least a morning in ECT to observe what that looks like, and an afternoon or a morning in outpatient clinic too, to see what outpatient psychiatry is like. And then have an amazing clinical experience with learning how to counsel a patient with a substance use challenge, and walking them through how to do that, along with debrief, et cetera, at Strong Recovery. We have many people involved in the teaching of medical students, both in the clerkship and through all 4 years. Many of those are in this room or on Zoom, but it certainly does take a village. We've got faculty, many residents are very active teachers. We've got nurses and social workers and advanced practice practitioners and psychologists and psychology trainees who really help to provide a well-rounded educational experience for our students. And I am forever grateful for all the members of our village. It is a big lift because we want our students to graduate with an excellent understanding of psychiatry and how to approach patients with a psychiatric history in the future. So what is my challenge? I think there's many challenges, but if I think about the big picture in the home of Meliora, how to improve education on a consistent basis, thinking about how to teach everything I want the students to know in 4 weeks' time is a big lift. And so if you all were to think just real briefly, what would you want students to know and to walk away with their medical student education about psychiatry? I'll just give you like 30 seconds to think about that. All right, less than 30 seconds. So just email me everything that you just thought of, because I'm sure I'm missing something. But it's a big task. It's a big lift. We're thinking not just about knowledge in terms of psychiatry and the diagnoses and treatment, but also about the art of psychiatry, the art of interacting with patients, and how to manage your own countertransference and affect, how to collaborate with other professionals. The list goes on and on and on. And I think one of the common complaints that I get from clerkship students is I just ask them to do so much during the clerkship, and that's a fault of mine potentially, because I think everything is important. And so I think you all probably agree that psychiatry is in every single medical specialty that there is. And a lot of our students, although we try to recruit the best of the best in psychiatry, they're going to be throughout all of the medical fields. So teaching them what they need to know to be comfortable and confident and dedicated to treating people with a psychiatric illness, or maybe just risk factors for that, or other life stressors. So it's a big lift, and I'm honored that the school has trusted me with that lift, but certainly I can't do it alone. So I just wanted to highlight a couple of the different challenges, although you can think probably that there's many, but there's a lot of strengths and opportunities, and it's a really exciting time for us. So one of the challenges, and we just talked a little bit about grading, is that students need grades, and they need grades that reflect their performance. And grades are super important when it comes to residency matching, because as of this year's cohort, step 1 is now pass-fail, which means the clerkship grades really are more important than ever in terms of making sure that they get into the residency of their choice. But we've got issues with grading, right? They're subjective, especially with written evaluations, with narrative evaluations. When you introduce people into anything, you're going to have bias. So thinking about how to address potential bias in grading in terms of racial bias, gender bias, et cetera. So we're walking up to that. Dr. Rosenberg and Dr. Sheftel and I are walking up to that to try to put together something that really helps to address some of that systemic issue. And also fairness too. Am I giving the person who deserves a high pass, et cetera? And then the idea that grading by itself, when you introduce that interpersonal connection, is very subjective. So how to maybe enhance the grade to be a little bit more objective. And then also the quality of the evaluations. So we put together some action steps, things that I've done and I'm working on in terms of how to make the grading for clerkships even better than it was. So a few years ago, we de-identified all of the grading packets for the medical students that come through the grading committee of the clerkship. That way, for the committee themselves, we are removing any potential bias in terms of pronouns, names, etc. We also have a very robust grading committee that consists of both medical educators, residents, but also folks who are not intimately involved in medical education, to try to have a breadth of experience, a breadth of abilities, and a breadth of backgrounds as well. We are working, as I just mentioned, on a faculty development series to address bias in grading. Of course, it's not going to be sufficient, but at least it's a start, and that's going to be in process from now until forever. And then Dr. Ainsworth has already talked about the narrative evaluation instrument. The other piece is faculty teaching, right? So we have an amazing department full of amazing faculty members and staff members who are very motivated to take care of patients, to teach, to do what they need to do to make sure that our department is as good as it can be. With that in mind, there's a challenge. There's also a tension in terms of trying to recruit the best of the best into teaching, because people are pulled in many different directions. So this is something I've been thinking and talking a lot about over several years, and I'll continue to think and talk a lot about it until all of my goals are met. And in the era, in the home of Meliora, I don't think that will ever happen, but we're working on it. There's a path, at least. So recognizing who is a great teacher, who provides the mentoring, the advice, the advocacy that the students deserve and benefit from. How do we ensure that the teaching itself is best quality? How do we disseminate the fact that we have so many different amazing educational products, making sure that they're highlighted, not just because students really appreciate them and I appreciate them for the teaching, but because it is scholarly activity, and how to make sure that people get credit for that effort and the work that they're putting in, not just on their CV, but in the department, nationally, and also when it comes to promotion too. So promotion as a clinician educator often relies on things like publication, but a lot of things that we do as clinician teachers is not publishable, but it's certainly scholarly work. So how do we walk up to those questions? So just taking a step back and looking at the data, we've got data in terms of the faculty teaching and the quality in this medical school during the third year. And as you can see, the translation didn't occur really well, but the psychiatry clerkship is right there. And so you can see the psychiatry clerkship faculty teaching over the last 3 years, it's been pretty good. I'm proud of that. And especially proud that if you see the other couple clerkships that are even better than psychiatry, they have robust, profound faculty development in their departments. So without a structure of faculty development, we're still doing a great job, but I think we could do even better. And so one of the things that I've been talking with others about is how to develop the faculty development in our own department. How do we support our faculty and teachers and increase best practices in terms of education and support them in terms of their time and efforts in what they do on a daily basis. So if we could think about that challenge in terms of faculty development, faculty time, lack of faculty time potentially, and also trying to think of standardization of the teaching that medical students do. Medical students are going to many different clinical sites, and they are being taught many different concepts that are very important, but there's some nuances and some standardization that needs to happen in terms of key concepts. And one of those is the mental status exam. So thinking about this as an issue in terms of how to standardize teaching, in one example, mental status exam, how to increase objectivity in terms of clerkship grading, how to manage the fact that I've already got the students stretched extremely thin during the day with the clinical experiences that they're partaking in. We came up with the idea of putting together an online module to teach the mental status exam, and also an assessment module to assess the learning of that module. So working in interdisciplinary team with two clinical psychology doctoral interns, Zoe Ning and Ellen Hart, as well as a medical student who's currently a 4th year, Simran Kaur, and an instruction design specialist, Jenny Peck. We put together an online mental status exam module. So first, we needed to kind of do an assessment to see what students felt that they wanted more help with in terms of the mental status exam, and how they thought it would be best taught. So we did kind of a focus group and preliminary survey from students who had completed the clerkship in the previous year, and asked them what they thought they needed. And then you could see that a lot of them wanted help with the top 3 aspects of mental status exam was judgment, affect, and insight. And then their preferred method of instruction was a video review. So working with the 2 psychology doctoral interns who were fabulous in terms of really figuring out what videos would portray which aspects of the mental status exam, and then how to integrate that into an online module that has both educational components to the module, a handout that's kind of can go along with that module, and then self-assessment throughout the learning module. It was a big lift, and I'm very proud of the work that they did and that we did to put this together. So this is something that the clerkship students are now required to do. Sorry, and you're welcome. The learning module itself takes about an hour, and the assessment itself, depending on how much time you take as a tester or testee, it could take anywhere from 15 minutes to about 36 minutes or so. And then we're using the score on that assessment module to add to the grade. So this is separate from the clinical grade. It's another component of grading, hopefully to, again, increase the objectivity of the clerkship grades. So our next steps, this is just an example. I just took a screenshot of a video and then a sample question of the learning module. So folks can answer the question, and they get real-time feedback in terms of whether their answer was correct or needed revision. So far, after we put those together, we did a pilot. We asked students who had, again, already taken the clerkship what they thought of the learning module, and most thought, you could see that they thought it was really helpful and increased their comfort level with conducting a mental status exam. So we're going to continue to study that. So we are going to get more feedback, see how they do, look at the percent correct on the mental status exam assessment module, and then adjust as we need to. Other things, we've got lots of potential exciting activities. Again, given that psychiatry is the most important field in all of medicine, there's a lot to teach. And so how to really garner effort and motivation in terms of faculty, and how to teach them best practices in teaching and all the other things that you see. Thinking in the future about potentially a simulation activity in psychiatry. I'm very excited that Dr. Fu is working on how to enhance the learning about the biopsychosocial formulation in the 2nd year mind-brain behavior course. Hopefully we'll be able to integrate that learning into the clerkship. Also brainstorming ways to potentially introduce a medical education pathway in the residency, so we get resident champions, getting credit for the work they do, because we already have, and I'm looking at one of them, we already have resident champions that are doing lots of work, and having a pathway and structure for that can be profoundly helpful. And then also we've got our amazing psychiatry interest group, which is now called Psych Student Interest Group Network, Psych Sign. It's a national interest group. So I'm very excited about the future of psychiatry in this medical school, in this department, and beyond. So I'm going to pass it along to Dr. West, and I'm happy to answer any questions at the end.
Right. Thanks, everyone, for having me here today. I'm Jennifer West. I'm the director of the the psychology doctoral and postdoctoral training program. And my roles in education also extend to psychiatry. So I have the privilege of working with the child psychiatry first-year fellows in our psychotherapy seminar, and then I also do some teaching over in dentistry with peds dentistry residents as well. But today I'm going to focus on our psychology training program and specifically some diversity, equity, and inclusion initiatives that we have going on. I'm not going to be able to cover all of what we're doing, but we really have a lot happening from before trainees even get here in terms of the recruitment process all the way through. So I'll focus on a couple today. One of the initiatives we started was focused on I'm actually gonna skip, my slides are a little out of order here. So was really focusing in on what was happening in our community. So this was something that we started in 2020, 2021, that training year, which was in the context of the murders of George Floyd and Daniel Prude. And then of course, COVID, which we know there were several healthcare inequities that really kind of rose to awareness during that time, as well as a lot of mistrust directed at Asian and Pacific Islander groups specifically. So we really wanted to focus on having more increased recognition and appreciation within our training program of understanding the history of our community, so where we're living and working, and this slide here really highlights that for our program, many of our trainees are not from the Rochester area. This is a map of over the last 2 training years where our incoming trainees trained. So as you can see, it represents many states as well as the territory of Puerto Rico. So in part, this was really designed to be helpful to trainees coming here, many of whom had never even set foot in Rochester, because now, of course, we're doing virtual interviewing. But it was also really for those of us who grew up here or who have lived here for many years. Because as we know, this is a history that like our experience of history has really been from a Eurocentric perspective, and who's really, who we come to know is really influential and who gets attention in our community is also pretty biased. So we really wanted to draw attention to that and really think about that carefully and intentionally in our training and in the work that we do. And this kind of highlights some of the things that we focus on in that work together. And so we have 2 different initiatives that I'm going to focus on during this time. And it has 2 parts. So the first is what we call Welcome to Rochester. And it involves some pre-reading and viewing of some media content. And then the second part involves a tour of the Ganondagan Historic Site. And this is just kind of what some of the overall goals are. And I won't read those to you. You can read those. But again, really focused on understanding the city of Rochester historically and currently, and how some of the racial and social injustice that happened in the past and continues to happen currently impacts the people who we live and work with and care for today. And then also the diverse ways that individuals in our community who are from historically underrepresented groups have contributed to our community. So the pre-work that happens before the group meeting, our group meeting where we cover this content and really talk about it, happens at the end of August. Our training year starts August 1st. So our trainees watch Shane Wiegand's Grand Rounds presentation that happened here in our department a few years back, that really focuses on redlining and how that's impacted Rochester, as well as some of the racist policies that occurred in our own medical center. So if you haven't had a chance to watch that, you can access that through the Grand Rounds YouTube channel, I believe. And then our trainees also read through the Common Ground Health reports, of which there are 3 listed, and then meet, so to speak, 2 influential Rochesterians by reading interviews that were conducted with them through local media sources. And here are the ones that we've focused on historically, and we often add to that list. And so then after all that, our trainees have put time and effort and reflection into doing that pre-work, we come together for a group meeting. And it really follows kind of restorative practice, listening circles, if you've been a part of those before. So we have a round where our trainees share a reflection that they had about the readings or media that they viewed. And they each go around and do that. And then the next round is a connecting circle where they can respond to something somebody else said or share, an additional insight they had. And we send out possible reflection questions before the meeting, but certainly we let people freestyle too and really share whatever sort of came to their mind or heart as they were doing this. And then the other piece is that we traveled to the Ganondagan Historic Site with members of the University Counseling Center training program. We have a two-hour guided tour there that changes from year to year in terms of what the focus is. This year's was around kind of the healing properties of nature. And then we do a brief debrief at the end where, again, individuals share reflections and insights. So that's what we do at the beginning of our training year. And then we have what we call our amplification and allyship series that happens throughout the year. We usually have 4 to 5 meetings. We used to call this our Structural Racism Podcast Club, but we changed the name for a couple of reasons. First of all, we really wanted the group to have more of an action-oriented perspective to it. So really thinking about how can we move from our discussion and reflection to action, particularly around allyship. And then the podcast term, we used to really focus solely on the use of podcasts, but we recognized that we had a blind spot around that. We have a lot of trainees in our program who are deaf or hard of hearing. And when it comes to podcasts, there's although we were providing transcripts, there's a much bigger cognitive load that comes from having to read a transcript. And so we've really tried to move towards content that either has ASL interpreting or that we can get interpreted. And so again, the overall goals are very similar to what I spoke about earlier. We change the content each year, kind of depending on what's happening in the world. Another shift that's happened, though, over the course of this series is we're really trying to make it much more Rochester-based, if we can. So for an example of that was our educational disparities talk. In our first year, used an episode from Nice White Parents, which again, if you haven't listened to that on Serial podcast, that's a great one. But then we decided we'd really like to focus more on the educational disparities happening here in Rochester. And so we now use an interview with Justin Murphy. So these are just some examples. And in the interest of time, I'm not going to share my other initiatives so that we can have questions and Dr. Rosenberg can finish up. But I'm glad to share them at another point in time. So thanks for your attention.
Thank you so much. I just want to say a few things by way of winding down. The first is I know that Dr. West had a slide of acknowledgements, which includes both a number of faculty and others who participate in their diversity work groups, as well as the Psychology Training Committee and educators. I certainly would be remiss if I didn't alert you to the fact that any of these activities, all of these activities, and particularly the ones that involve integration, innovation, creativity, and really anything execution oriented, would not happen without the support of our educational administrative staff. That's headed up by Mary Lee, and I see her in the audience. I'm not just saying that because she's here, but thank you. She really likes when we draw attention to her. Thank you. Okay. And then we're going to end with an invitation. So for those of you who are thinking, oh my gosh, this is sort of amazing. I came to this field because I want to be of service to patients and communities, but many of us can also participate in that same mission by being a teacher, and many of us already are. So if you are wondering, how do I do more of what you're talking about? How do I become involved? Some things in here that are low-hanging fruit would be to notice the education and training and learning that's happening around you. Ask what students and trainees and even faculty are learning to help advance the way that we think together. Offer feedback about what you see. Suggest ideas for things that are gaps, either in the way that we think about things, the care that we provide, or the way that we teach. Be curious about another person's perspective. That in itself is a very influential form of learning. And then last but not least, when we invite you, please say yes. We have many opportunities for everybody in this room and on Zoom to participate as a teacher, and we welcome all of you to this very creative work. In closing, I just want to say thank you to my panel here of extraordinarily talented, thoughtful, creative, and innovative educators, and pretty awesome women, I will add. Thank you for your leadership and for sharing today. And with that, I'll say thank you to you and invite any questions. Just to look up there. Okay. Yes, please, Dr. Baines.
I'm so excited to learn about some of the innovation that's happening that I wasn't even explicitly aware of. So this is cool. Cool to see all of the incredible innovation that's happening, so much of which, is hard to even keep track of. What I would invite people to comment on is how much of this was spurred on the kind of major disruption to education that happened in COVID, and how much did that fuel a kind of re-examination of how do people learn best, and how can we tap into this space to change things and kind of use that energy to innovate or be creative in different ways than you had previously considered.
Thank you. So I'll turn to my panel and invite a very spontaneous but also innovative response.
Sure, I can just say with our initiative, we did launch it. Am I not mic'd? Okay, can you hear me now? All right, so the initiative I talked about, we did launch during COVID, so we actually found it fairly easy to do that way. We used the breakout group function, and what we've done recently is we've had our first meeting in person and really sort of had to figure out how do we do that? Are we a big enough group that we can all meet together? Do we split up? And so actually Zoom lended itself really well to our initiative. It didn't really spur from that other than what I spoke to earlier about what was happening in the context of COVID and the healthcare system.
I think all of us experienced how innovative we could be during COVID, and the capabilities just expanded our horizons exponentially. We got things done in a manner that was just remarkable in terms of pulling people together and making things happen that we didn't think possible. Specifically for the two things I mentioned today, what were not specifically from COVID, but certainly trying to be creative in terms of online learning and other forms of learning, I think might have developed in that pathway for sure.
I'd also like to add, I've been an educator for a longer time than it looks like I should have been because of my youthful appearance. Thank you. But I will say I've never experienced a time so dynamic as the last several years. So if there was a place to make a case for turning crisis into opportunity, to borrow from Dr. Lee, it has been this time. But I will say we have learned so much about how the regular old school traditional ways of doing education leave so much to be desired in the directions in which we're moving. So whether it was COVID or the murders of George Floyd and Daniel Prude and others, to see these as springboards into a much more relevant, forward-thinking way of teaching and learning, I'm very grateful for those. And so I look forward not to many more pandemics, but to more opportunities to be thoughtful about why we're doing what we're doing and how to do it better. Thank you for the question.
And I'll just add, in terms of the CL Fellowship and MIPS, the rotation had been in development prior to COVID. But during COVID, the team went to Zoom multidisciplinary meeting, which brought all the challenges therein. But actually, what came positively out of that experience is that a voice that we didn't previously have in the interdisciplinary meeting was nursing. And it was during that time that we made a change to have nursing lead that. And so that was paramount in the functioning of that meeting and interdisciplinary professionalism and collaboration, which came from COVID.
I would just add to Kathleen that the other thing that really became clear during COVID was the importance of community building and how challenging that was when we were all apart, as well as the importance of helping trainees who are often here for a short period of time, aren't from the community, connect with the greater community. So I think that's the spirit of some of what we've done in our program, and one of the other initiatives that I didn't talk about, which is really connecting trainees well before they even get here with resources in their community that aren't just about housing, but are about where do you get your hair styled, or places of worship, or businesses owned by people of color, things like that, that I think really can help people feel at home in this new home.
Well, I will say thank you so much, not only for your attention, but for participating as a teacher alongside of us. We are so grateful for everything that you do on behalf of our learners, ultimately for our patients, but we're grateful to you, and we look forward to working with you. Thanks very much.